Alrighty folks, I'm not trying to beat a dead horse here, but questions have been keep coming up from the last video that I made. The last one was from Bangkok, which was a follow-up to the Vietnam video, but a couple of interesting other questions came up that I figured I will do. By the way, I'm coming to you here from the lounge, or the business lounge in Doha, the Qatar Airways, and I'm sitting here and I figured I'll spend a little bit of time until I catch my next flight back to Boston. So there are going to be people passing by. I hope you're not distracted by it. Either way, what I wanted to talk to you about in this one is the question that came up about the reimbursement. I had mentioned in the previous video that reimbursement would be probably your best option in these types of cases in managing patients, so that they're happy with your attempt to save their teeth, but at the same time, if it doesn't work out for them, you can always reimburse them the additional fee from that first visit. So here's the way it works out. Imagine that if you have 2 visits where the root canal is done with the full fee. Let's make that, for the sake of simplicity, $100 being charged for the root canal to be done in as many visits as it takes generally. Okay, in many cases you go inside the tooth and you find out that there is a fracture in the tooth, or there is something going on that you didn't know ahead of time. In those types of cases, you would generally be charging a fee that ends up being a percentage of the full fee. In some cases it could be 30%, in some cases it could be 50%. It's never usually the full fee if mid-operatively you find out that the tooth is unsalvageable and has to be extracted because of a crack. So in a sense, you know, the patient doesn't take all of the risk in these types of situations. You end up kind of sharing that risk along with the patient. And this is the way it's been done for a long time. There is in fact insurance codes here in the US for unsalvageable teeth, and that ends up being somewhere in that order of 30% or so of the fee. So it all depends. You know, sometimes you could look at a tooth ahead of time during your treatment planning, and you may not know if a tooth is salvageable, and just every tooth that you see is questionable. You don't want to recommend extraction, because then the patient's really not going to benefit by knowing if the tooth could have been saved or not. So in those types of cases, what I would normally do is I would discuss with the patient and say, look, the root canal fee is this way. We do what we call an exploratory procedure. We go inside the tooth and find out if the tooth is salvageable, and that if it is, then we'll do the root canal for you. But if it isn't, then it would be, I don't know, like I said, 30% of the fee or 50% of the fee. Now, one thing that happens in these types of cases in which you have to do 2 visits or 1 visit, when you do a 1 visit and you would have preferred to do 2 visits to find out, you could basically treat it in the same exact way as an exploratory procedure. And what that means is that you are essentially telling the patient that we're going to do the procedure, because remember, by the time you're done with the cleaning and shaping, you can just obturate that tooth very quickly. So there's no reason to have the patient back. It's better to terminate the case, which means to complete the case. Then you will have the most information about the tooth, whether it worked or not, because calcium hydroxide is not going to be the answer to find out. In many cases may not work with calcium hydroxide, but the moment you obturate the tooth, the procedure works out. And what I would do in those types of cases is I would tell the patient, look, what we would do is we would finish the procedure, and if it doesn't work and we decide to have the tooth removed, we will charge only half the fee. So we'd lose half the fee essentially on that front, but it's important to kind of think in terms of the long run and keeping your patient satisfied, and not focus on being penny wise and pound foolish, in the sense that you're going to destroy the relationship with your patient and your referring dentists in that way. So the idea of doing a 50% reimbursement is very, very legitimate and very, very logical, and it's very, very fair. So the patients would understand that everybody's taking some chances in these types of situations, and that's something you can do in many cases when you go inside the tooth as well. When you don't know if the tooth is working, you can say that, look, we're going to go inside the tooth and decide. If it works, we'll complete the case, but if it doesn't, it will be just 50% of the fee of the procedure for us to find out in an exploratory fashion. And then if you decide to complete the case, you can extend the same courtesy to the patient by having them come back in a month or 6 weeks or 8 weeks, again, as we talked in the previous video, by having a very strong restoration inside the tooth, which would be some type of a bonded BC liner, as opposed to putting cotton on cavit, which is not adequate for long-term follow-up. I think this is probably the best way to manage these kinds of cases in which you create the most amount of value for your patient, and that's essentially the goal. Now, another question that I come up that I thought was important is that, well, if you're going to do it in 2 visits, what should be placed in the canal, or should calcium hydroxide be placed? And if it is, how long should calcium hydroxide be put in place? Let's just quickly review what is the function of calcium hydroxide. Calcium hydroxide as an intracanal medication, it does essentially the same thing that it does for vital pulp therapy. In vital pulp therapy, the reason we use calcium hydroxide is because of the fact that it creates a thin necrotic layer because of its high pH. So that necrotic layer is the sterile necrosis of the pulp tissue that will then reorganize and hopefully be repaired into normal tissue. But furthermore, the high pH of 12.8 or so for calcium hydroxide will also be highly antimicrobial to almost all oral pathogens. So this is another reason that we would use that both for vital pulp therapy and for the same reason during root canal therapy in between visits, because studies have shown, I think it was by Benz et al., that during the mid-op appointment you will have regrowth of bacteria inside the root canal while you are waiting. And this is something that obviously you don't want to have bacteria regrowing inside your root canal, because you'd be back at square one and essentially would have no purpose to what you did during the first visit, because bacteria has regrown. Now, how long should it be in there? Many studies show that essentially the calcium hydroxide effect peaks at around 1 week, and what happens is that after 2 weeks, or certainly after a month or so, conventional calcium hydroxide formulations almost become inert, and you can, if you have a patient that comes back after a while, you will find out that bacteria is even growing inside the tooth, even though calcium hydroxide is still present, because that has essentially been buffered out to calcium. The hydroxyl ion has turned into water at that point, and it's going to wash down. That's part of the reason why it does wash out of the canal as well. Now, there are newer formulations of calcium hydroxide, and one of them is the BC Temp that we've developed. And the BC Temp, what it tries to do is essentially use the bioceramic formulation to release calcium hydroxide slowly, so that you can maintain a high pH for much longer than conventional just calcium hydroxide powder and water formulations. So that's what BC Temp does, and that's why it is used in that way. So anyway, these are the 2 points I wanted to say. Don't be shy in terms of patient reimbursement. That's not an admission of guilt. That whole thing is just about good communication with your patient, to let them know what you know, what you don't know, and the question of risk that you're taking on their behalf. That is, they should be completely and utterly thankful for you doing this for them, because this is really an exceptional value and service in terms of finding out if a tooth is savable or not, by you investing a lot of your time and effort into finding that out as well. And I think in time, when you do more and more of these, and as you find out which cases work and they don't work, you will become a better treatment planner, and you'll find out, you know, in your own way, what kind of cases work better in your hands, which kind of cases don't work. And of course, if you're a general dentist, you have to realize which cases you should be referring out to your endodontist to do. And if you're an endodontist, then you would know which kind of cases you should be replacing with implants. Alrighty, folks, just wanted to make this another quick one, coming here to you from the airport in Doha. And I guess if these questions keep coming up and I find them to be interesting, I'll make these short, informal videos for you. I hope you enjoy them. Alrighty, guys, have a good one. I hope you weren't too distracted by all these people running. If you can imagine the looks I was getting here, people passing by, looking around, oh, what the heck are you doing out here? This is the business lounge. Alright, guys, see ya.